The urinary system is responsible for removing metabolic waste from your blood. There are only four major organs in the urinary system: the kidney, the ureter, the urinary bladder, and the urethra. The kidney is where urine is formed. The ureter, the bladder, and the urethra are simply tubing and holding tanks for the urine until it can be eliminated from the body. The kidney has several functions. Primarily, it filters the blood to remove and eliminate soluble waste from the blood. It also regulates the composition and volume of the blood. Blood volume is directly related to blood pressure. The kidneys are involved in maintaining water, electrolyte, and acid-base balance. During starvation, the kidneys can actually be involved in gluconeogenesis, the production of glucose from non-carbohydrate molecules. Erythropoietin is the substance that stimulates the bone marrow to produce red blood cells. It's manufactured by the kidney. And finally, the kidney converts vitamin D to its active form. The kidneys are located in the lumbar region at the level of T12 to L3. The right kidney is slightly lower than the left. The liver is on the right side of the body and is a very large organ. It pushes the right kidney down just a little bit. The kidney is shaped like a bean and has a hilus. This is an indentation on the medial side. The ureters leave the kidney here. Nerves and blood vessels enter and leave the kidney at this point. There is a tough, fibrous connective tissue capsule that surrounds the kidney that's known as the renal capsule. Also, there is a fat pad around the kidney. This helps protect and insulate the kidney. During extreme starvation, this fat capsule may deplete. If that happens, the kidneys may drop to a lower position. This can kink the ureters. This is a condition called ptosis or nephrotosis. If the ureters are kinked, urine cannot drain adequately from the kidney. Urine will back up into the kidney, putting pressure on the filtration units and causing kidney damage. This is known as hydronephrosis. This cross-section view shows the internal structure of the kidney. The outer layer is known as the renal cortex, and the inner layer is known as the renal medulla. These blood vessels, the arcuate arteries and veins, are the dividing point between the cortex and the medulla. There are two major regions in the medulla. The medullary pyramids are the triangular shaped. They appear to have these little stripes in them. These are actually the collecting ducts for urine. And then we have the renal columns. The renal columns are in between the pyramids, and this is how the blood vessels are going to get to the renal cortex. The renal pelvis is this hollow space in the hilus. This is where the ureter is connected. Each renal pyramid drains into a hollow space known as a calyx. All of the calyces merge to form the renal pelvis. Urine is collected and drains into the renal pelvis so that it can drain into the ureter. The kidney has an excellent blood supply. 25% of the total cardiac output each minute goes to the kidney for filtration. The renal arteries take the blood into the kidney, bringing the blood in to be filtered. The blood is filtered by microscopic units in the kidney called nephrons. There are millions of these in each kidney. The blood is then collected and drained by the renal vein back into the inferior vena cava. The nephron is the filtering unit of the kidney. There are three major parts to the nephron. The glomerulus is the knot of capillaries that is involved in the actual filtration of the blood. The renal tubules can be divided into several parts. The glomerular capsule or Bowman's capsule is the part that surrounds the glomerulus and collects the filtrate. Then we have the proximal convoluted tubules, which are a series of coiled tubes near the glomerular capsule, the loop of Henle, which loops down into the medulla, and then the distal convoluted tubules. These are also coiled tubules, but they're called distal because they're further away from the glomerular capsule. The distal convoluted tubules will drain into the collecting duct. These are the tubes that run through the pyramids, giving them that striped appearance. They deliver the final urine to the calyces of the renal pelvis. This shows the structure of the nephron. These blood vessels are the dividing point between the renal cortex and the renal medulla. The artery that comes through here is going to feed the glomerulus, that tuft of capillaries that are involved in filtration. The renal tubule indents to surround the glomerulus and collect the filtrate. We then have the distal convoluted tubules. The loop of Henle loops down into the medulla. We come back up and we have the distal convoluted tubules, which empty into the collecting duct. Several nephrons will empty into the same collecting duct. The collecting duct will go down through the renal pyramid and will empty the urine into the calyx that's attached to that pyramid. The glomerulus is fed by an afferent arteriole. This is what brings the blood to the glomerulus, which is a knot of capillaries. The afferent arteriole has a fairly large diameter. The efferent arteriole is going to drain the blood from the glomerulus. The efferent arteriole is smaller in diameter than the afferent arteriole. This means that there's a fairly high blood pressure in the glomerulus. This is what forces the fluid and the solutes out of the blood. This is the process of filtration. The renal tubules will recapture most of the filtrate and return it back to the blood using the peritubular capillary beds. The peritubular capillary beds arise from the efferent arteriole. They are going to follow the renal tubules closely. Here you see the efferent arteriole breaking into the peritubular capillaries, and you can see how these are woven all around the distal convoluted tubule, the loop of Henle, and the distal convoluted tubule. Because we have lower pressure in these capillaries, it's going to be easy for them to reclaim materials from the filtrate that is in the tubules. Urine formation is a three-step process: filtration of the blood, reabsorption of necessary materials, and finally secretion of unwanted materials. Filtration is a non-selective passive process that occurs in the glomerulus. Because of the high blood pressure in the glomerulus as a result of the size of the afferent and efferent arterioles, most of the blood plasma is filtered from the blood into the collecting tubules. The only thing that stays in the blood are large proteins and the blood cells. The filtrate will contain waste products, ions, water, glucose, and amino acids. Some of these things we want to get rid of, but some of them we need back. Because this is a pressure-driven process, if blood pressure is too low, we will have less filtration. The second step of urine formation is reabsorption. Pretty much everything left the blood. We have water, amino acids, glucose, and some ions that we need to return to the blood. The renal tubule cells will take up these substances. This happens primarily in the proximal convoluted tubules and somewhat in the loop of Henle. We will transfer material from the filtrate in the tubules back to the peritubular capillaries. We'll restore blood glucose levels, blood amino acid levels, the levels of ions, and we will restore the water level in the blood back to normal. The final step is secretion. When we recaptured some of the materials we needed, we also recaptured some material we didn't want, and we need to get rid of it. Secretion is going to be the movement of materials that are in the peritubular capillaries back into the renal tubules. Hydrogen ions, potassium, creatinine, which is a protein breakdown product, and drugs are secreted from the peritubular capillaries back into the distal convoluted tubule. This secretion process is important for getting rid of some substances that we either reclaimed or never filtered out. When the kidneys can't perform these functions, dialysis is used. With dialysis, the blood is artificially cleaned by a machine. An individual is hooked up to the dialysis machine. Their blood is circulated through the dialysis machine so it can be cleaned and then returned back to them. Urine should contain nitrogenous waste from protein breakdown. It's yellow in color because of urochrome. That's the yellow pigment in urine. It ranges from light straw to dark amber in color. The more concentrated the urine, the less water in it, the deeper the color. Urine is usually slightly acidic. It ranges from a pH of 4.5 to a pH of 8, which is slightly alkaline. Diet and disease can change the pH of the urine. Normally it will contain some sodium and potassium, whatever the body didn't need, urea, uric acid, and creatinine, which are the breakdown products of proteins, and hydrogen and bicarbonate ions. This is part of the pH balancing function of the urine. Abnormal constituents can indicate some sort of disease. For example, glucose in the urine typically indicates diabetes. White blood cells in the urine typically indicate an infection. If red blood cells are seen in the urine, this indicates that there's some sort of bleeding going on inside the system. Kidney stones can cause this, as can trauma to the kidneys. Protein should never be in the filtrate. If it is, it means that the glomerular membrane is damaged in some way. The ureters are thin muscular tubes that connect the kidneys to the bladder. They move the urine by peristaltic contraction of the smooth muscle layers. Once they get to the bladder, there are valve-like folds that help keep the urine from flowing backwards into the ureter. Kidney stones or renal calculi are concentrated uric acid or calcium salt crystals. These are usually formed in the renal tubules and then break free. As they're trying to pass through the ureters, they cause pain when the ureter wall contracts. One of the ways to treat kidney stones is with lithotripsy. This uses sound waves to help break the stones into smaller pieces so they're not so painful to pass. The urinary bladder is a sac that has a smooth muscle layer. It's collapsible. It will collapse down if it does not have urine in it. This is for the temporary storage of urine before it leaves the body. The urethral opening is the opening in the bladder that drains the bladder. There are two other openings, the two ureter openings. Notice how the ureters come down behind and urine fills the bladder from the bottom up. This is another thing that helps prevent backflow. These three openings describe an area in the bladder known as the trigone. The urethra is the tube that carries the urine from the bladder to the outside. Again, peristalsis is used in this tube as well. The urethra is longer in males because it has to pass through the penis. It also has a dual function in males. It's part of the reproductive system and it carries the sperm. There are two sphincter muscles associated with the urethra. The internal urethral sphincter is an involuntary muscle. It's closed when urine isn't passing through it. The external urethral sphincter is a voluntary muscle. You learn to control this muscle so that you can eliminate urine when you want to. Micturition is the act of voiding or emptying the bladder. Incontinence is an inability to control the external sphincter. Besides filtering the blood for waste products, the kidney also has the control of water and electrolytes. This is primarily controlled by hormones. Two things drive this control mechanism. One is low blood volume. Now you can have a low blood volume because of rapid blood loss, but more frequently you have it because of dehydration. You just haven't taken in enough fluid. The hypothalamus monitors for this, and when it realizes that the blood volume is low, it triggers the release of antidiuretic hormone from the posterior pituitary. Antidiuretic hormone tells the distal convoluted tubules that they need to reabsorb more water from the urine filtrate. This water returns to the blood and helps restore blood volume. Low blood pressure will also trigger some control of water and electrolytes by the kidney. The cells of the kidney will trigger the adrenal medulla to release aldosterone if blood pressure gets too low. Aldosterone tells the renal tubule cells to reabsorb more sodium. Again, this is at the distal convoluted tubule. Wherever sodium goes, water follows. So if we're saving sodium back into the blood, water is following along and going back into the blood as well. This will increase blood volume, and when we increase blood volume, we increase blood pressure. Diabetes insipidus is a homeostatic imbalance that occurs if the hypothalamus is either damaged or cannot produce enough ADH. As a result, even though the hypothalamus may be able to detect that we're dehydrated, it can't secrete ADH, so we can't conserve water. As a result, these individuals experience polyuria, excessive urination, and stay dehydrated. This is treatable by taking ADH. Addison's disease is a disease of the adrenal medulla. It is hypoaldosteronism. The adrenal medulla fails to supply enough aldosterone to the blood. This means that even though the kidneys are picking up low blood pressure and signaling the adrenal medulla to release aldosterone, it can't. The body can't conserve sodium, so we lose both sodium and water in the urine. These individuals experience polyuria, excessive urination, and also have electrolyte imbalance. The kidney also has the function of balancing blood pH. Blood pH should be very narrowly maintained between 7.35 and 7.45. If the blood pH rises above 7.45, we have a condition known as alkalosis. Below 7.35, the condition is known as acidosis. Acids are constantly being produced by metabolism and being continually added to the blood, disrupting the pH. We need to maintain blood pH because imbalances can lead to problems with nerve transmission, muscle contraction, particularly cardiac muscle, and enzyme activity in all tissues. To understand how pH is balanced in the blood, we need to know about buffers. Buffers are simply chemicals that prevent drastic pH changes in a solution. They either absorb or release hydrogen ions. Think of them as sort of like a hydrogen ion sponge. If there are too many hydrogen ions in the solution, they soak them up. And if there aren't enough hydrogen ions in the solution, we can kind of wring them out like a sponge and add some back to the solution. Blood pH is controlled by three factors. The first is buffers in the blood. This is primarily the bicarbonate buffer. These buffers can handle small changes. Usually the typical day-to-day changes can be handled by the buffers in the blood. But if there are large pH changes for some reason, these buffers need a little bit of help. The second way we can balance pH is through the respiratory control. You'll remember that carbon dioxide is carried in the blood as bicarbonate, so we can adjust carbon dioxide levels in the blood by breathing, and this can assist the bicarbonate buffer system in the blood. And the third way we can balance blood pH is through renal control. The kidney tubules can either excrete or conserve bicarbonate ions. This also assists the bicarbonate buffer system. Additionally, the kidneys can actually excrete acids that are formed by metabolism. This takes a little longer than the buffering systems, but it is a more potent way to control blood pH. Polycystic kidney disease is a genetic degenerative disease. The nephrons are unable to release urine and become fluid-filled cysts. These cysts eventually obstruct urine drainage. If enough of the kidney is converted to cysts, the kidney will be unable to function at all. These individuals typically need transplants when their kidneys begin to fail. Hypospadias is a less severe congenital problem. This is seen only in males. Here, the urethral opening is on the underside of the penis instead of being at the end. At some time during the first year of life, corrective surgery is performed to relocate the urethra.